Good afternoon, everyone.
Hey Patrick.
Hey Patrick.
Hey. All right. Sorry, was that for me or anybody else? All right. Let's just give ourselves a couple of minutes. We just had another bidders conference that ended like 2 minutes ago. So I'm just going to take a moment, allow people to come in, get ourselves situated, get our note-taking hands ready, uh, and then we'll get started in just a moment. Thank you. All right, let's go ahead and get going. I am tempted to just keep that voice going, but I think I'll lose track. So, thank you very much for joining us this afternoon. For those of you who do not know, my name is Patrick Stonehouse. I use he, him, his, but anything with respect is fine. And I work for the Chicago Department of Public Health in the Endemic Infectious Disease Bureau's Community Health Services Division. And today we're going to be talking about our request for proposals for HIV primary care in the jurisdiction. This bidders conference will be recorded. The recording will be posted to a CDPH website some point in the near future, along with a question and answer document that will capture all questions issued during this session, as well as things we receive via email or through e-procurement. And so I'm going to go ahead and get started. Please let me know when you can see my screen.
I can see it.
Thank you. All right. So again, this is from the Endemic Infectious Diseases Bureau, Community Health Services Division, our request for proposals for HIV primary care. Um, the outline, we're going to do a quick overview of the Endemic Infectious Disease Bureau portfolio, mostly external activities, so the services and activities that we fund organizations to do, and that's an important distinction because we also do some direct services and a bunch of other activities ourselves. We're going to talk a bit about the RFP for HIV primary care. We'll talk about alignment with Healthy Chicago 2025, guiding principles and values of the Chicago Department of Public Health. For for those of you who do not know, the services portfolio supported by Endemic Infectious Disease is meant to be an interconnected system of services as opposed to standalone services and activities that organizations do independent of one another. We really work hard internally and with our partners to ensure that folks are aware of what each other are doing, are able to complement it, fill gaps, amplify excellent work, and support when challenges are experienced. So all of our RFPs are constructed so that this is an overarching system that is designed and built to support people in whatever area of need they have that we've got a service category in place for. The portfolio integrates funding across 8 different funding sources: CDC, high impact HIV prevention and surveillance, CDC STD, STI work, CDC viral hepatitis, Ryan White, Part A, HRSA's Ending the HIV Epidemic funding, Housing Opportunities for Persons with HIV, City of Chicago corporate funding, and Illinois Department of Public Health funding. Wherever possible, we want services to be conducted in a status neutral way, meaning that there are mirrored versions for persons with HIV and persons vulnerable to HIV. It does pertain to the HIV primary care RFP, in that the expectation is that folks are going to be providing clinical care for people with HIV and clinical care for people with demonstrated vulnerability to HIV who are on pre-exposure prophylaxis. Wherever possible, we want organizations to use a syndemic approach, meaning that they're addressing the concerns of individuals related to HIV, certainly, but also talking and providing services related to sexually transmitted infections, viral hepatitis, tuberculosis, and Mpox as appropriate. And I will zero in on Mpox for a moment, just in that we want folks to know that while this is HIV primary care, when things happen like what is happening now, wherein we're seeing uh, cases of mpox among individuals who have HIV, who are in care but are not vaccinated against mpox and don't know that mpox is a thing, the expectation's gonna be and is currently, but will continue to be, that organizations funded to provide HIV primary care are talking to every single client about mpox. And this is particularly important for those individuals who have HIV because that's the population within whom we're seeing the most severe outcomes related to mpox. So hospitalizations, the few deaths that we've seen in the jurisdiction have been amongst people with HIV who weren't vaccinated. So this is just an example of how syndemic approach is incorporated and expected of HIV primary services delegate agencies. And as with everything, we want all of our activities to align with getting to zero Illinois, other state and local plans, as well as national plans towards ending the spread of syndemic infectious disease and doing the best that we can to take care of those individuals who are experiencing syndemic infectious diseases. Generally speaking, the buckets of funding for the syndemic portfolio fall into four spaces. So we've got how to, which is really looking at uh, making sure that people know the information, know what services are available to them, and have supports in accessing and fully benefiting from those services. Housing, which is exactly what it sounds like. So this is housing opportunities for persons with HIV and housing opportunities for persons vulnerable to HIV. Health equity is all of our efforts, both in terms of our contracts, but also our own services and our monitoring and support of delegate agencies. It looks at the experiences of populations most impacted by HIV and what proportion or what level at which they're accessing services are being provided to them, what level at which the desired health outcomes are being achieved. And I'll talk about this again later on, but it's things like for HIV primary care, let's say, if you've got a viral suppression rate of 80% across all individuals who are accessing services, but your viral suppression rate amongst Black women is 40%, well, that's going to be seen as a problem, right? That we as a group need to work towards addressing. So it's not sufficient that across everybody aggregated up, it's an acceptable rate. Like we're going to look at each specific population of those that are most impacted by HIV. And then within healthcare, so the actual clinical service delivery in various ways. And this is the model upon which we built the portfolio. And it's important for folks to know that this model was not designed just by CDPH. This was something that was done in collaboration with our community planning council, other community partners, interest holders, people with HIV, people vulnerable to HIV. But the idea basically is that everybody starts at a spot where they are recruited somehow into screening. And then depending on the result of that screening, they either follow this path for people with HIV or this path for people vulnerable to HIV. And this acknowledges that like, there are barriers across each of those steps, but the outcome, the end goal we have for both of these paths is engagement in clinical care and adherence to medical treatment. HIV primary care for and ART for people with HIV and PrEP for people vulnerable to HIV. And that those steps between these, the barriers and challenges folks experience between these, need to be addressed by a collection of support services that are available to both paths. And then surrounding all of that are more environmental factors of sorts. So marketing and communication, housing services, resource coordination, community development, which is our systemic and structural interventions that are population specific, and services for people who inject drugs. Uh, Important for folks to know the grant that had been services for people who use drugs, which fulfills that last box on the left there. That has recently been transitioned from the Syndemic Infectious Disease Bureau over to the Behavioral Health Bureau of the Chicago Department of Public Health so that it can be integrated in with other harm reduction activities and contracts that they have in place, largely with the same organizations we were funding for services for people who use drugs. So it's just let's remove that redundancy and consolidate things all over into that one space. So services for people who use drugs is no longer a part of our Bureau of activity, but it is still something that we work with behavioral health on to address any and all concerns related to substance use and how that impacts people's ability to progress through this path. So, HIV primary care. The City of Chicago, acting through the Chicago Department of Public Health, is looking for qualified organizations to provide HIV primary care to promote the use of antiretroviral medications for treatment of people with HIV in the Chicago eligible metropolitan area and HIV pre-exposure prophylaxis for persons vulnerable to HIV within the city of Chicago. These different geographies are based on the funding sources available. So Ryan White Part A, HRSA ending the HIV epidemic funding, those cover the Chicago eligible metropolitan area. All the pre-exposure prophylaxis work is done within the city of Chicago, and that's because the funding that we use for that purpose is either going to be CDC funding or City of Chicago corporate funds, both of which are restricted to the city. There is a slight possibility of the ability to use some Illinois Department of Public Health funding in this. The IDPH funding that we receive is solely for PrEP implementation in the eligible metropolitan area outside of the city of Chicago. So depending on need, we may work to incorporate those funds in, but it's a very, very small amount, so it wouldn't really go very far. The EMA, the eligible metropolitan area, includes Cook, DeKalb, DuPage, Grundy, Kane, Kendall, Lake, McHenry, and Will counties. No, Will's not part of the EMA. Never mind. Will's not part of the EMA. That didn't sound right to me. HIV primary care will be funded through Ryan White Part A and HRSA ending the HIV epidemic funds for services provided for people with HIV and City of Chicago corporate funds or CDC funds for people with demonstrated vulnerability. Services may be provided through in-person engagements at clinics, medical offices, mobile vans, or telehealth engagements. Emergency rooms, important to note, are not supported by this particular funding opportunity. We do currently have 3 organizations funded to implement HIV primary care: South Shore Hospital, AIDS Healthcare Foundation, and Loyola University Health. These contracts end at the end of February 2026. So the contracts that are established through this request for proposal will start March 1st, 2026 and go through the end of February 2028. There are 2 optional 1-year extensions that will be issued at the discretion of the City of Chicago based on availability of funds, demonstrated need, and the performance of the organizations implementing these services. Approximately $633,000 are available through this RFP. So we say approximately because Ryan White Part A funding is issued based on resource allocation conducted by our Community HIV Planning Council. The Community HIV Planning Council has sole discretion and authority to say this percentage of all of the Ryan White Part A funding you get goes towards outpatient ambulatory health services. We are required to align with that allocation. So it is possible that the amount can go up or down. It all really depends on what we see in terms of the applications coming through and what the Community HIV Planning Council says in their resource allocation efforts. Common among all SID, syndemic infectious disease, community health services, RFPs. So this is stuff that's going to happen for all RFPs, and I know some of you have heard me say this, but this is my 7th one in 2 days. You might have heard me say this 7 times. When we receive proposals, all proposals are reviewed by this scoring breakdown. We are required to have panels of reviewers take a look at every single RFP. Panels are, or every single proposal, pardon me. Panels are required to be an odd number of individuals, no less than 3, and at least one member of each panel needs to be a person who does not work at the Chicago Department of Public Health. So we train those individuals, we give them the documents that they need, we give them the proposals that they need to review, we do like checks for conflict of interest and all that kind of stuff. They go back and they review the proposals. They submit to us their scores on an individual level for each proposal. We then take those scores and put them all together to create the average score for each proposal from that panel. If there are like significant if there are like big discrepancies between the scores, so like one person says this application should get like a 99, the other says it should be a 4, the other says it should be 0, we will bring those folks together and have a conversation to see what was going on that led to such vastly different scores. Then the product of that needs to be an agreed upon score per proposal. So those folks get together and say like, all right, we got it, we figured it out, we understand what each other was saying. These are the scoring levels that we're going to give to each of these proposals. any proposal that receives an average end score of less than 80 points will not be considered for an award. No matter how much I may like it, if the average score from that panel is less than 80, City of Chicago policy is that we do not pursue a contract with the organization behind that proposal. If no proposals achieve a score of higher than 80, the past practice is that we would reissue the RFP and start the whole thing over again. Really hope that doesn't happen, but it could, and I actually have seen it happen before. So, alignment with CDPH, guiding principles, Healthy Chicago 2025, and core values. So, as with everything that we do, uh, this RFP and the services that it funds need to align with the goals of Healthy Chicago 2025. And Healthy Chicago 2025 is the City of Chicago's plan to address the life expectancy gap between Black Chicagoans and non-Black Chicagoans. So this does that in two ways that I think are significant. One, chronic disease, HIV, these are or infectious diseases are contributors to that life expectancy gap. And so by way of providing increased access to and benefit from primary care for people with HIV, we reduce the likelihood of individuals passing prematurely due to their HIV status. And same with pre-exposure prophylaxis being provided to individuals, like reducing the likelihood or the chances of acquiring HIV in the first place, connecting individuals with all the supportive services that can help with that to address their other concerns. All these things help with people's health and well-being. But also, and we'll talk about this a little bit later as well, the expectation is that in the implementation of these services that we are paying particular attention to the experiences of populations who are disproportionately impacted by HIV. So again, that idea that I mentioned within the equity part of things earlier, if 85% of your client base is achieving viral suppression, but Hispanic, Latino, gay, bisexual, same gender loving men is at like 15%, then that's not an acceptable situation. And we need to be putting forth our efforts to address those concerns. So we will continue to do that in our monitoring and support of the organizations that receive contracts, but we also want to see how organizations propose that they will address these concerns and these realities that are being experienced by populations in our jurisdiction. So we also want to look at how, within that space of alignment with the CDPH mission and Healthy Chicago 2025, and this used to be addressed in prompts that we called dismantling racist systems, but we can't use that terminology anymore because of current administration environmental issues. We want to see a general alignment. Organizations should talk about that, talk about how leadership and decision making of the organization is guided by populations that are highly impacted by HIV and populations that are within your sort of organizational catchment, how leadership and decision making is impacted, and how you're holding yourself accountable to those organizations. We want to look at how you are preventing trauma and how you're providing trauma-informed services, how you're looking at the safety, well-being, and healing of clients and staff, prioritizing cultural responsiveness and recognizing historical traumas experienced by clients and staff, transparency of decision-making, and building and maintaining trust at all levels. And related to health disparities, which used to be known as health equity, because we can't use the word equity anymore, even though I think I got it through in a couple of spaces. How you're planning on using programmatic and non-programmatic data. So that could be surveillance data, it could be qualitative data through interviews, focus groups, what have you, to identify disparities and how you're going to change or adjust services, policies, and practice to address those disparities and increase the health and well-being of those populations that are most impacted by HIV. We also want to know about, again, how the extent to which folks who are members of populations that are most impacted by HIV and syndemic infectious disease were involved in the development of the proposed program and the involvement of any community advisory boards that your organization has. And then lastly, we are responsible as the recipient of these funds and as the health department for the city of Chicago to look at the health and well-being of the Chicago eligible metropolitan area when it comes to Ryan White Part A and the eligible metropolitan statistical area when it comes to housing opportunities for persons with HIV, and then just within the city of Chicago and sometimes Cook County, depending on the funding sources. So we want to receive the proposals, and it can either be like we've got a network of organizations that are going to provide these services, or it's going to be our organization is going to do this. It can be we're going to do a whole range or like a geographical range of the EMA, or it can be a very discrete section. It could be the whole thing. We really want to see what organizations come up with that they feel plays to their strengths, plays to addressing uh, the health and well-being of populations within their strengths. So it's really we want to see what folks come up with in terms of this is what makes sense for us and what we feel we can do either independently or in partnership. Um, all respondents, all proposals, we require that you list out where you're providing services in terms of counties, community areas, wards. And again, that's because it's our job to look at the collection of proposals that receive 80 points or more and put together the most comprehensive net of HIV primary care for the jurisdiction that we know includes like as urban as Chicago and as rural as other parts of Illinois that are very rural, which, there are parts of Chicago that are fairly rural, but like when we think about like some of the spaces in McHenry or in DeKalb, like there's some spaces wherein folks can't just get on an L, which we all know that, but we need to consider that as we're putting together our recommendations for award. And that's the presentation on HIV primary care. If you have any questions, you have a couple of different options. You can reach out to John Pfeiffer, who's our Assistant Commissioner of Contracts and Administration. You can send me an email with questions. You can send an email to hivfunding@cityofchicago.org. Comes to me too. Or there's a platform within iSupplier where you can submit further questions as well. And then lastly, we can take the rest of our 37 minutes to have a conversation about any and all questions that you've got. As I mentioned at the beginning, this meeting is being recorded and will be posted online. I'm also going to be preparing a question and answer document that will also be posted online. And in that vein, if you have questions, of course, feel free to like raise your hand and give voice to those. But if you would please at least like some level of shorthand in the chat just to make it easier for me to capture everything and make sure that I'm appropriately getting what you're trying to get across. And with that, we're good. So, what questions have you got? Justine, yes, please.
Hi, Patrick. Thanks for the summary, the synopsis for this RFP. I just had a couple of questions, but
Yep.
the first is really an access question. So I saw on the iSupplier site on the abstracts page that this particular RFP had been updated. Or it's listed as having been updated. The new number is 57107, comma 1. But when I actually try to access the PDF file, I keep getting an error message. It's saying the file won't open. I reached out to customer support, the iSupplier customer support folks, and they said to reach out to the agency who released the RFP. Um,
How dare
so
they?
I just want to know because we accessed the original RFP and that's what we're going off of. But I just want to know, is there a new RFP? Or has there been an updated RP and how does that impact the dates of submission, the dates for questions, that sort of thing? So that's the
Right.
first, I guess, main question I have.
No, that's solid and very, very thoughtful question. So, uh, no changes were made to the RFP. So if you have the version that was published before, it's the same exact thing. I did not change a word. The only thing that would have changed, and the reason there's an amendment, is the changing of the due date. That should be it, because I didn't touch a single sentence on this RFP before between then and now.
Okay, so what is the new due date? Because that's not listed. Right now, it's still listed as November 10th. And that was based off of the original release date of October 10th.
I do not know what the due date is at this point. But I know that the folks in the contracts administration have been working on getting all of that solidified, and then they should be sending out a notice either through e-procurement or some other mechanism like this is the new due date.
Okay, got it. I have other questions, but I see there's some questions in the chat, so I don't know if you want to take those and check them
Sure,
out.
thank you very much.
Mhm.
All right, so Matthew's question, do we need to submit separate budgets for domain 1 and domain 2? No, one budget for all should be fine. When will we know the new due date, given the RFP was 99% inaccessible until the 17th? Sometime this week, they're finalizing that information, the new due dates for all RFPs. I will say all of the RFPs we had published are getting extensions by at least a couple of days, if not longer, depending on how long they were out. Ooh, Sharon, can you give an example of how agencies prove Ryan White Part A funds were used as a last resort in the case of those grant funds? So, so there's a couple of different things. Um, the language in the payer of last resort requirement is that organizations implementing Ryan White Part A services must exert a reasonable effort to determine another funding source prior to using Ryan White Part A to do that service. So, what is reasonable effort? It is intentionally vague, but basically, through monitoring, was we monitor delegate agencies. One of the things we're supposed to be doing is like, all right, how are you able to show that you tried to see if you could pay for this through some other mechanism? Did you check for insurance? Does this person's insurance cover the service that you provided in Ryan White Part A? If it does, then you should use that insurance instead of using Ryan White Part A. So it's more on the back end at this point. There is a significant interest in doing some more proactive uh, sort of rule making around such things, but we don't want to be like overly rigid, right? So we still want flexibility in the use of funds, but we do need to adhere to this being a payer of last resort. So doing more formal guidance and trainings with delegate agencies on what is available through other funding sources, through Medicaid, et cetera. Um, and making sure folks know that and that they have policies and procedures in place for determining that Ryan White Part A is a payer of last resort. But great question. All right. Stephanie, I love this. I know you're not speaking about the new date in an official capacity, but I'd like to write the powers that be that the new due date of all RFPs should be no earlier than 11/17/2025. Would that be John Pfeiffer? Yeah, you can send that to John Pfeiffer. Or you can also send it to me and I will funnel it along to John Pfeiffer and our commissioner, Dr. Olusunbo Igai, who has been monitoring all this stuff. And just so you know, like the reason we wanted to get everything done quickly with this is so that we have like really not a lot of time, but that we have an appropriate amount of time to establish new contracts to begin March 1, 2026. So I know that there's going to be concern about extending deadlines because of the ripple that has. So if we extend deadlines, that means we issue our awards later. That means we execute contracts later. So acknowledging all of that, I will never stand in the way of advocacy. I also like I'm not supposed to, but I also wouldn't. So do what you need to do. Feel free to have me involved if you so desire. Go forth. Okay, so Justine, is HRSA EHE a funding source for this RFP? It only states that Part A and corporate will support services provided for HIV primary care. Yeah, this is a thing that we discussed a lot internally. There is language in the RFP. Let's see if I can find it exactly. So CAC may reallocate funding across selected respondents during contract extension negotiation. There's usually some language in here that we sort of may need to change. I know it's in here somewhere. I'll try to find it, but like we wrote stuff in this, like if we need to change funding sources, we will do so as appropriate.
Okay, so then but when if we apply for this, we are only submitting budgets for Part A and for corporate?
Yeah.
Okay.
Yeah, that's all that's necessary. We can bring in the EHE side of things as we need to.
Okay.
All right. Cameron, how many awards do we expect to make under this RFP? I don't know. And I kind of like that. So as you saw, we had three, was it three? Yeah, three organizations that were funded to do HIV primary care before. I feel like I'm forgetting one. It was three, right? Yeah, South Shore, AHF, Loyola. Um, so we only funded three before. I am interested in seeing uh, what organizations have learned, from the last, 6 years of implementation of HIV primary care and population-centered health homes and essential support services, et cetera. Also, we know that there are new organizations that are in the field a bit, who may be interested. And we've also done a decent amount of work over the last couple of years to try to build up the capacity for primarily federally qualified health centers in their ability to provide HIV primary care and other Ryan White Part A services. And so I'm very much interested in seeing so like based on the quality of applications that we receive, how many awards do we need to issue in order to provide the coverage that we're responsible for providing? It could be a mix of like here's a couple of really large scale ones, and here's like three or four, fairly small ones. I'm interested in just seeing how it plays out. So I can't give a solid number. I just want to see what happens. Is a low reduced barrier care a requirement for HIV primary care like it is for PACHH? There is a statement in the RFP that says that programs should implement in addition to other services. So yeah, there's a couple of different ways that can work. So yes, the lower reduced barrier care model it's going to be more of an expectation, or it is a requirement. We want to see it with the HIV primary care providers. The mechanism of doing it was sort of challenging to figure out how do we without turning HIV primary care into a population-centered health home, because we want it to be something other than that, like more focused on just the clinical side of things. Um, how do we do that while still involving an expectation of lower reduced barrier care? And what I think is going to happen, and this, for those of you who know, the reason that's important is when we were putting together the portfolio initially, we were like, all right, population-centered health home looks rad. It's all this stuff. We're done. And folks were like, no, what if I don't want my primary care in the same place as I get my psychosocial support services? You're forcing me into a situation like that. That's messed up. We shouldn't do that. So we separated them out. So we have population-centered health home, which is clinical and supportive. You have primary care, which is just the clinical, and then you have essential support services, which is just the supportive. So if you were to add HIV primary care and essential support services, you would get population-centered health home. So I'm think there's a couple of different ways in which I anticipate low or reduced barrier care to be implemented at the HIV primary care uh, organizations. And I think it's going to be a negotiation with those organizations that receive funding to do HIV primary care as to how we make it work. It could be like that institution is using other resources that they have to provide the personalized incentive side of low or reduced barrier care, that they're going to use another funding source to do the intensive case management, or it could be that we're going to foster connections between the HIV primary care agencies and other service providers through other contracts. We'll sort of see what happens. Okay, we can apply for both HIV primary care and population-centered health home RFPs, and those evaluations will be independent of each other. Yes. Stephanie, you got your hand up?
Muted. Artifact of an answered question, excuse me.
Oh,
I do want to add for the benefit of everybody, I will send a very detailed message to Mr. Pfeiffer explaining the situation, but if you get that error in the main bid list for the city's page, you have to log in and then type in the contract number, the solicitation number, and then you can pull it down to see the RFP. So if you're blocked by that, that's how to access the RFP for each of these solicitations.
Is there an error message that you received though, Stephanie?
I have a screenshot of it. I did not get it today sampling it a few places. So, but it is, like I said earlier, slow as molasses and it's timed
Yeah.
out.
Would you, and forgive me if you already did, but would you send me that screenshot?
Yeah.
Okay.
I haven't gotten it today, just to
Yeah.
reiterate though.
No, that's fine. It's actually more planning purposes. And since we have a little bit
Okay.
of time, like that's going to be my workplace Halloween costume.
Yeah, that's pretty great.
I think so. All right. We got this space until 4 o'clock, y'all. So please feel free to continue popping the questions in. Again, all questions will get written responses published on the web. And again, you can send questions to me directly, to John Pfeiffer, to hivfunding@citychicago.org, or through the Q&A portal in iSupplier. Okay, Justine, thank you. What types of letters of support will we need for this RFP? Really looking for letters of support from uh, entities that can attest to your ability to pull off what you're proposing to do. It can be like we're in a formal partnership with X organization, or it could be like through other formal partnerships with this organization. We have seen their capacity to do X and Y. Whatever it is that you feel is the most appropriate and gives the most accurate reflection of your organization's ability to carry out what you're proposing. But there's nothing like it, there's nothing more sort of like formal requirement than that.
So there's no like min or max number.
Yeah.
I mean, I guess the min would be one, but of
Yeah.
letters of support to attach. Okay.
Mhm.
Oh, one other question too.
Mhm.
And this is kind of similar to the PCHH one, but the health equity zone information is not attached in the RFP, I think, for this RFP as well. And I could put that in the chat.
Please
There's a
do.
question about like what
Mhm.
health equity zones are you supporting or
Yep.
providing services in? Yeah.
Yep. I appreciate you doing that, and we will make sure that that information gets out. Yeah. I know it similarly went through like a big old mess with like, can we even call ourselves health equity zones in the current environment when equity is seen as being a negative? Um, but yeah, I will find something and be able to provide that to you. Oh, Stephanie did it. Lovely. Thank you very much.
But it's not in the RFP, of course, so that would be great.
Uh-huh. Understood.
I have another question, Patrick. This is
Oh, yeah,
kind of a
yes.
general question.
Hmm.
So, so we're currently funded as a PCHH, and I think that Stephanie had or someone had asked this question about applying for both PCHH and primary care and being assessed independently. What if agencies review all the RFPs and they decide this particular RFP is probably more in alignment with what the services that they provide, but it may not be what they currently are funded for. And let's say we go in for primary care, but we're, like I said, we're in PCHH right now. Um, in CDPH's, I guess, assessment of applications, um, after assessing the full kind of scope of applications, would it be fair to not assume, but fair to, I guess, assume that CDPH would review and say, no, maybe they are better off as a PCHH versus even though they didn't apply for like that RFP. Does that make sense?
It does.
Mhm.
So once upon a time, we had this great plan of issuing all of the RFPs in like a cycle almost, or like that would allow them to build off of one another. So like start with population-centered health home, and if you're not successfully awarded as a population-centered health home, click this box if you'd like to be considered as a HIV primary care. And then when the HIV primary care RFP comes out, you don't have to do anything because you already got your application, and only folks who only wanted to do primary care would submit their applications at that point. Our system is not set up for that. So after lots of conversations and like loving arguments with folks in procurement, we ended with a no, we would not be able to consider that. So if your HIV primary care application comes in, we do not have the ability to say, you know what, this would be better as a PCHH and vice versa. So it has to be based on the quality of that application, that proposal independently. That said, once a contract is established, so let's say your organization, well, and incidentally, I actually anticipate some organizations that are currently population-centered health homes to apply to become HIV primary care providers. Uh, it's having had some conversations with some folks, they're like, we should have been that instead of this, and vice versa. Like there are some organizations that have said we should have been a PCHH, but we went for HIV primary care instead. I anticipate shifts in that way, and I think that's fine. Uh, Play towards what your organization has the greatest capacity to accomplish, rather than like getting into a space where it's not as strong as it could be. So, however, once a contract is executed, so let's say in your instance, you're currently a population-centered health home. You either don't apply for the PCHH RFP or don't get awarded the PCHH RFP, but you do apply for HIV primary care. We don't have the ability to, at the point of approving and awarding your application, to shift it from primary care provider to a PCHH. What we do have the ability to do is on implementation and ongoing support and monitoring, make adjustments through a couple of different procurement mechanisms that we have of adding funding in different spaces to a contract, either short term or long term. So there are things that we can do afterwards, but we can't do anything with the applications other than review them for what they were proposed for.
Okay, thank you. That was helpful. Yeah.
And really, like, I think the next time around, we will be able to do that sort of like a filtering down process of applications. So you didn't get a PCHH. Would you like to be in essential support services? Would you like to be considered for primary care, et cetera? I think we'll get there next time around because there's a lot of interest in doing it that way, just because it reduces the burden on everyone involved. Go ahead, Stephanie.
Just to make sure I understood you correctly, if we apply for both PCHH and HIV primary care, and if we don't get PCHH, there's an opportunity to turn into like PCH Light as awarded a primary HIV care grant?
No. So if you apply for population-centered health home and you don't get it, I do not have the ability to consider your
Oh, no.
application for HIV primary care.
No, we if we apply to both.
Right. So if you apply to both, your applications will be reviewed independent of one another.
Right.
So it is possible that we will make a recommendation for award for your organization in both the PCHH and the HIV primary care space. I would come close to putting money down on that recommendation should we make it, not being supported by the executive committee of the Chicago Department of Public Health, because they'll say, like, why do you have this organization getting two awards? And if there's justification in the proposals of like the the volume of outpatient ambulatory health services that is being provided actually warrants these two separate contracts. Like, okay, we can figure it out. But it's
No,
not a,
actually,
hmm,
yeah, I don't mean that. I'm sorry to interrupt you. I just didn't want you to have
no,
to waste
please.
time on my misstating. It's more that I'm trying to understand what I heard from Justine, your answer, Justine, that
Hmm.
let's say we apply to both. We don't get PCHH, but it sounded like in the post-award period, if we are a HIV primary care grantee and we proceed that way, that there is some fungibility with funding to support other services that may not have been in the original scope of HIV primary care.
I want to be very clear that there are procurement processes we can go through to make adjustments to awards. So yeah, if you're awarded HIV primary care and over the course of implementation, negotiation, what have you, uh, there are a couple of different procurement paths that we can take to try to add additional funding sources, additional service categories to your contract. That's a process. It's not like it is not a light switch. It
Oh
is
yeah.
a lengthy process that involves identifying the funds, making the compelling argument, going through at times months of review and argument, and then it can land as a you can add funds to this organization for the remainder of this budget period, or depending on some uncertain circumstances, it could be okay. We've adjusted sort of the global purchase order for this organization to address these things. So it's a possibility, it's an option that we can try to explore. But I want to make it clear, like it's not an easy thing to do, but it is a thing that we can
Hmm.
do, and we have done in the past.
Thank you.
Yep.
Sorry, I hope I'm not beating a dead horse here with this question, but just want to make sure I'm fully understanding. So say we apply for both population-centered health home and HIV primary care. It sounds like CDPH likely will not make awards for both of those grants to the same organization, but will instead, if they award one, will award the one that they see that applicant is the most qualified for or most appropriate for. Does that make sense?
It makes sense. I don't think it's as it's a little bit more flexible than that. So it is possible that the CDPH will make a decision based on the quality of the applications that an organization could get both a PCHH and an HIV primary care award. Uh, I can see an eventuality within that. So let's say like you're a healthcare system that has multiple sites. Let's say that one of them is in Grundy and the other three are in Cook. So you can say like we're going to do a PCHH model with the three we got in Cook, and we're going to do an HIV primary care out in Grundy, and those are separate things, but it's the same institution. I can absolutely see us saying like, okay, that makes sense, move forward. And I can see, but wait a minute, why wouldn't that all just be population-centered health home? And it would be like, how compelling is the argument in the proposal and in negotiation around implementation of award?
That makes sense. Thank you.
Yeah. And then Barbara, you wrote for the proposed contract budget terms, should the budget be structured? Assume lag flat funding for all years. Yes, at this point. And I think, yeah. Okay. Justine, could you confirm that the percentage of admin costs should not exceed 10% of the program budget? Yes. 10%. And we will go through and comb all of the RFPs to make sure that that is applied. This is part of the Ryan White legislation, 10%. So it's not even up for local interpretation. Go ahead, Barbara.
Hi, thanks, Patrick. This may be a kind of a duplicate kind of question or redundant, but in terms of the Planning Council determination of funding allocations, will those it sounds like those allocations will essentially be aligned, the process will be aligned with the review and award process for these proposals. That, you mentioned that again, that you are working in harmony with those recommendations and requirements. But at the same time, you're describing a degree of fluidity regarding the number of awards under the mix of primary care and PCHH. So it just sounds to me like this will be kind of a harmonized process. Is that a correct perception?
Yep. And I'll walk you through how it works, just in case. And forgive me if folks already know this. So the Community HIV Planning Council, which is the Chicagoland HIV Integrated Planning and Action Council, which is a federally required community planning body for all jurisdictions that receive Ryan White funding. They are responsible and have the sole authority for saying to recipients, such as Chicago Department of Public Health, of the 27 point whatever million dollars in Ryan White Point Part A funding you received, X percentage of it needs to be spent on outpatient ambulatory health services. Y percent needs to be spent on food bank and home delivered meals, et cetera, throughout all the service categories that they are determining warrant funding. We have to abide by that in aggregate. So let's say they come out and say like outpatient ambulatory health services gets 22% of your total award. All right, so that 22% gets spread across two RFPs of ours, population-centered health home and HIV primary care. Within each of those RFPs, there are multiple awards. So how we distribute those resources, how we distribute that 22% or whatever it is across those two RFPs and across all of the contracts within each of those RFPs, the Planning Council has no discretion over. Like once they've made their resource allocation, it's on us to implement. We can't exceed it. We can't really underseed it. We can't go underneath it either. Like it has to, like this is how much we issue out. Yeah, how it goes out is up to us.
That's very helpful. I think the service category kind of structure, that makes perfect sense. I think that makes perfect sense. Thank you so much.
Yeah, of course.
Yeah.
And so like the reason we're providing estimated award amounts or funding amounts is that the Planning Council hasn't finished their priority setting and resource allocation process yet. So they're going to be finishing it over the next month or month and a half. We are going to be, and we've already discussed this with them multiple times. It's something we're all sort of aligned with. When they're done with their resource allocation amounts, the percentages that go to each service category, we're required to make sure that the awards we issue per service category across all of the funding, all of the RFPs align with those resource allocation directives from them.
Perfect. Thank you.
Yep. Stephanie, go ahead.
Sorry, it'll take me longer to type than to ask this question. Going back to Justine's question about the low reduced barrier care as a requirement of HIV primary care, if it does not fund non-medical like case management services that are required as part of low barrier care, are we supposed to demonstrate a funding source to provide those services that are not directly funded by this RFP?
So if, like, basically, like, in your proposal, how are you going to pull off low reduced barrier care?
Yes, because it's technically a combination of medical slash behavioral slash social complexities that we're overcoming, helping patients overcome.
Mhm. Um, yeah, through like partnerships that you're going to bring into bear. Yeah.
Okay. I assume they have to be, if we don't do it in-house for the benefit of the people, they have to be established partnerships, not just you will coordinate after the fact. Like,
Yep.
okay. Thank you.
Mhm. All right. So we've got 4 minutes. Thanks for being with me on this. This was actually fun. I appreciate you.
Oh, thought of another one.
Yay.
Sorry. When are the others coming out? I don't think you said substance use is not out yet.
It is impossible to say. So there are
Okay.
multiple RFPs that are in review by various parts of the city of Chicago structure. And just around substance use, specifically substance use outpatient, that one was delayed. Like we had written it, and then there was an idea like, wait, this couldn't this be partnered with a substance use outpatient contract that exists within the behavioral health bureau that would just have like, here's a funding source from Runway Part A that allows for these same organizations to provide the same service for people with HIV. And so that delayed everything a bit. And it came to like, no, like procurement wise, we would not be allowed to do that. So then I had to go back like, all right, well then let's restart taking a look at that RFP as a standalone thing. So I
Okay.
don't know when it's going to come through.
Okay. Thank you.
To follow up on Stephanie's question, do you know how many are left to come out?
Um,
Because I think so far I've seen like 8 or 9, maybe, or 8 maybe RFPs so far, but I wasn't sure if they're like
should be
how many more to
nine.
expect.
Should be 9 that have come out. Specifically within the healthcare access or Ryan White Part A funding, it should only be like 1 or 2 more, but there are other, like the housing opportunities for persons vulnerable to HIV. RFP is
Mhm.
going to come out. Um, there's the systemic structural interventions RFP should be coming out relatively soon. That uses HRSA ending the HIV epidemic funding. Um, yeah, maybe a couple more substance use outpatients probably going to have to come out.
Okay.
And any others that I think of, I don't know. Honestly, I'm thinking about like, what if we put together an RFP that establishes a lead coordinating organization that establishes secondary subcontracts with community-based organizations that can't afford to be awardees of the Chicago Department of Public Health to put off like events and population-specific recruitment in different parts of the EMA.
Oh,
That would be awesome,
yeah.
but I gotta write it. Anyway. So Sharon, you wrote, can you remind me if both population-centered health homes and primary care are included in the Chicago PrEP element? Yes. HIV primary care delegate agencies are expected to provide PrEP clinical care for individuals with demonstrated vulnerability to HIV. And this is actually, they were before too, we just never really did it because it was written into the RFPs, but we just never really did it in a meaningful way. So this time it is like, all right, we're going to be more focused and make sure that this does happen, that these agencies are doing the prep side of things as well.
Oops.
Barbara?
Oh, I know we're just on the deadline here, but um, related to both primary care and PCHH, I was looking, are there currently published City of Chicago service standards for this categories, the service categories? I was not able to easily locate them.
Yeah, that doesn't surprise me. The service standards need to be updated. They have not been updated in a
Years,
long time.
a few years, right, right.
More than a few. It's been a long time. So they need to be updated. We know that. But they haven't been as of yet.
Okay. So, but I just wondered if the relationship of aligning service categories as defined by standards of care in terms of descriptions, is that an expectation? Should we look at the HRSA sites? I guess that's, I know the questions may not extend that far, but just in terms of our internal reviews and references, I hope that question makes sense.
It does. I would, if you're able to get it, I would look at the most recent Chicago eligible metropolitan area service standards and align with those, acknowledging that they are likely to change in the next year or two. And the reason I say that is that we are not, it's like the Ryan White service standards are the minimum, right? We can
Right,
go beyond those,
exactly.
but we can't do less than
Right.
those.
Right, exactly, right. Oh,
Oh,
thank you.
and yeah, the stands.
Thank you,
So
thank you, Stephanie. Yeah,
that's right.
maybe I missed it. I must have just missed it. Sorry. Thank you.
All right, it is 4:02. Thank you all very much. We'll close this out again. Feel free to continue sending questions to myself, John Pfeiffer, Assistant Commissioner, HIV funding at citychicago.org, or through the portal in iSupplier. And best of luck to you all. And I'm really looking forward to all the great work we can continue to do. Have a lovely rest of your day.
Have a great day. Thank you so much.
You too,
Absolutely.
thanks.
Thank you. Bye.
Thank you.
Thank you. Bye.
Bye.